Good afternoon, my friends. The doctor's in the house. Welcome back to another episode of To Your Health with Dr. G. My name is Dr. Mark Gomez. You can also call me Dr. G. And today we're going to talk about an issue, a topic that is important to all of us. This is the first of a two-part series called Obesity Wars. So again, welcome to our new listeners. Welcome to our returning listeners. So here's what we do on the show, To Your Health with Dr. G. Each week, I bring on a guest and panelists, my friends and professional colleagues, and we talk about various health topics. Today, we're going to be talking about obesity, and this is Obesity Wars Part 1. Now, before we get into a little bit more about the topic itself, let me hit you real quick with a disclaimer. All right. The content of To Your Health with Dr. G is for informational and entertainment purposes only, and that the content is not intended to be a substitute for professional medical advice, diagnosis, and or treatment. Further details can be found at www.toyourhealthwithdrg.com/disclaimer. Again, welcome everybody. Thanks for everybody joining on Facebook Live at To Your Health Dr. G. Also, follow me on Instagram and Twitter. You can also visit me on my website at www.drmarkgomez.com. All right. So today, guys, we're going to be talking about a theme important to all of us, a theme that is a growing worldwide epidemic. We're going to be talking about obesity. So I'm going to hit you with a couple quick facts before we introduce our panel. So here's a couple quick talking points that we're going to talk about today. Number one, obesity is a chronic disease and requires longer-term and structured and multidisciplinary management. Obesity remains largely underdiagnosed and undertreated. And we're going to talk about some of the barriers that are out there on why this is happening. The highest rates of obesity are seen in the United States of America. Not too much of a surprise, and we may get into some of that a little bit later. Established guidelines are infrequent and inconsistently followed by healthcare practitioners, another barrier that's out there towards treatment. We'll talk a little bit about that. We all need to become more engaged, patients and practitioners, the design of effective obesity management protocols, and the use of small considerations can improve healthcare practitioner-patient interaction regarding obesity and improving obesity-related care and outcomes. So again, my name is Dr. Mark Gomez. I'm a practicing internist. I work for Edward Hospital in Bolingbrook, Illinois. I've been in practice for 11 years, and I'm excited to talk about this topic, again, the first of a two-part series of Obesity Wars. So join with me today. I've got a great group of panelists, and I want you guys that are out there listening or watching to really heed their words. They're going to talk about different strategies, their own experiences, and how they're doing their fair share to help tackle this problem. In the end, to help address obesity, we really need public-private partnerships and really a community approach to do our best to make this public health concern become less and less of an issue moving forward. So my first guest today, I've known her for a long time. Dr. Ann Davis. She and I go way back to when I first started at Edward Hospital. This is back in 2007. She's also a fellow Loyola grad like myself. So we got to give a shout out to the Ramblers. But Dr. Ann Davis and I go way back. She's a cardiologist, everybody, and she is fierce. And again, I've known Ann for a long time, and she just has a great sense of care for her patients, and her patients really, really do well as far as their outcomes are concerned. So Dr. Ann Davis is joining us today. She's with Advocate Medical Group, Advocate Heart Institute. You'll find them at www.advocatehealth.com. So Dr. Ann Davis, welcome to the show. And why don't you just give us a few brief introduction about yourself? Where did you do your training? How do you attack this theme that is very important in cardiology?
Well, thank you so much for having me. I am from Chicago. Went to school at Loyola University, as you mentioned, for medical school and training. I went to University of Illinois at Chicago for my fellowship in cardiology. We see many, many patients with heart disease, obviously, and obesity. And I think the main thing is to broach the subject and start talking about it. I think if you could start talking about it, then you can do something.
Excellent. And that's one of the things that we'll talk about in a little bit about barriers that are out there, is that we just don't have these discussions. And for a whole host of reasons, we're going to hopefully try to break down some of those myths out there and chart some of those barriers and make sure that we can actually attack this issue head on. My next guest, he and I also go back. I've got like my Lola crew here today. Dr. Zaid Jabbar. He and I first met in residency in the internal medicine program, and I was a year ahead of Zaid in practice, and I still remember this great story. Zaid and I were working on the geriatrics ward, and I was responsible as a senior resident. I was responsible for just planning out schedules and everything. This is back in 2005 at the Hines VA, and I was planning out schedules, and then Dr. Jabbar goes to me as my intern. He goes, Dr. Gomez, you should take the day off. I can get you the schedule now. I'll take care of that. And so it's just fun that the intern at the time was giving the senior resident a day off, which is great. But Dr. Jabbar and I were partners at one point in actually private practice, and then he moved on to build up his own practice as well too. So Dr. Zaid Jabbar is from DuPage Medical Group. He is board certified in internal medicine as well as obesity medicine. And Dr. Jabbar, you can find him also at DuPage, www.dupagemedicalgroup.com. And welcome, Dr. Jabbar, to the show. And why don't you tell us a little bit about yourself and some initial thoughts on the obesity epidemic?
All right. Thank you, Dr. G. I should mention that you were a great senior resident. I learned a lot of stuff from you.
Thank you.
So I grew up in Madison, Wisconsin, so that naturally makes me a Packer fan, and which doesn't go too well around here, but that's okay. We still all like each other. I went to medical school at the University of Wisconsin, came to Loyola for residency, and been practicing internal medicine and obesity medicine for the past 10 years, and currently in the DuPage Medical Group Weight Loss Clinic. I would say the biggest challenge we have with obesity is making sure that our patients understand that it's a complex disease. It's a complex disease, and that needs a multidisciplinary approach. We have to get all the tools in our toolbox to tackle this tsunami. I call it a tsunami. It's a complex disease. We need nutrition. We need exercise. We need behavioral modifications. We need medical management, whether it's blood tests, medications. Also, we have surgical options that are available. And now, hopefully, we'll have even more options in the future. But I would say the main challenge is educating the patients that it's a complex disease and needs a multiple disciplinary approach.
Excellent. Thank you, Dr. Jabbar. And there's no doubt that the individuals that do best on obesity management are the ones that are involved in a multidisciplinary approach. They have the better outcomes, without a doubt, and less disease burden as well too, and more likelihood for a chance of maintaining success over a long period of time. My next guest is Ms. Barbara Taylor, and I've just gotten recently the pleasure and the privilege to meet her. She is with the DuPage County Health Department. She's a consultant, and she's got an interesting path on how she's gone kind of like from A to B in life. She's been very much involved in the community for a long time, prior with the YMCA, the YWCA, but she's got a really great passion for child obesity and some of the things that we're doing right now in the community. So welcome to the show, Barbara. Why don't you give us a little bit about yourself, tell us a little bit about, and how do you see this issue of obesity?
Great, thank you. I grew up in Michigan, and my first degree is in child development, so hence my interest in children and families. My second degree was in not-for-profit management, where I worked 30 years for the YMCA as a program director, as a specialist, and as a executive director of a local YMCA. When I worked for the Y, we did a fair amount of work in healthy living. It was the YMCA mission from the beginning. So my background, even though it was with children, it was also in healthy living initiatives. When I retired from the YMCA, I took on 2 contracts, one with the health department to look at obesity prevention in early childhood, and have worked with a number of child care centers throughout DuPage County to address environments and what can we do to really create environments obesity and reaching healthy weight in DuPage initiative. And right now we're working in worksite wellness, doing environmental assessments and then action plans, and then working those action plans.
Excellent. Well, thank you for being on our show. My last guest, those of the return listeners and return viewers, they've seen this gentleman on the show before, but for the new listeners out, I had to bring Mr. Chad Earl back because just his take on things, his take on disease burden, his kind of his mastery of even physiology is just amazing. So we've got Mr. Chad Earl. He's a certified health education specialist. He's got a master's in nutrition and wellness. He's also a personal trainer. He's a strength and conditioning coach. He is like a renaissance man. He does a lot of things, you can tell. But Chad Earl, owner of IntegratedWellnessOnline.com, www.integratedwellnessonline.com. Chad, welcome back to the show.
Thank you, Dr. G. It's great to be here, and I'm excited about the topic today.
Right, please tell me your initial thoughts on obesity and how you see it.
Yeah, I think obesity tends to confound and confuse some individuals because the obesity itself is a behavior most of the time, but yet that disease burden that it's created takes on its own management issues. And so I think you're correct when you say it takes a multidisciplinary approach to both manage the conditions of obesity, but I tend to look at obesity as kind of a psychosocial and an emotional condition as you relate to long-term management. What you do to treat obesity is simple, but yet the support and engagement with lifestyle and your obligations tend to make maintaining the behaviors very difficult.
Excellent. Thanks, everybody. Again, welcome to the program. So how I kind of break this down is we have this in segments. And as a physician, when people come into our office, we usually call it the chief complaint. That's why they present to us. And so the chief complaint of the hour is, what are we doing now to deal with the obesity epidemic, and what's going to happen if we don't? So let me give you a couple stats real quick. Global obesity rates are only rising. Men, it's estimated that 266 million men worldwide have obesity. Women, 375 million. In the USA, 37.7% of adults with obesity, 7.7% with severe obesity. That's a BMI defined as greater than 40. There's been a 10% increase in the prevalence of obesity since 2005 and 2006, and we're seeing a 600% increase in prevalence of severe obesity since the mid-1980s. And certainly one of the things that we see, another issue that we see in the country is certainly the health disparities when African Americans are 1.5 times as likely to be obese as compared to white adults. And in the child population, 20.2% of children aged 2 to 19 are obese in the African American population versus 14.3% of Caucasian children. So in my practice, this is and everybody can talk about this. In my practice, obesity is certainly an issue that we see on a daily basis. And as a practitioner, one of my challenges is that as we went through our training in medicine, we didn't get much exposure. And I think that's something that the public at large may not be aware of. There's actually only a few medical schools that actually really integrate obesity management and nutrition in their curriculum. And actually, back in the late 80s, to the National Academy of Sciences, they had talked about how you want to have at least 25 hours in the medical school curriculum in nutrition. And I can certainly come here and say we certainly didn't have that at my alma mater, as much as I love them. And so what the reality is that a lot of physicians, and certainly from the primary care standpoint, are not apt to be able to manage and handle obesity. And then certainly we need to talk about the long-term effects of that. So I want to ask the first question that I have to Dr. Davis. How do you approach, as a cardiologist, you're seeing a lot of the related to obesity in your practice from a cardiology standpoint?
Well, we definitely see rates of heart disease, rates of diabetes soaring, but even arthritis and knee problems that ultimately need surgery. It pretty much ravages most any health system that you have. But the point is, we want to try to shift that to prevention. I don't want to do a stent. I don't want to do bypass. I don't want you to have anything like that. Prevention is going to be the key. And you're right. But it wasn't just Loyola across the entire country. Yeah. No one had. But I think that's going to be the focus of it, and having people know that it's not all or nothing. They can start slow and build little by little. You don't have to do a marathon overnight, but I just tell people make small goals, keep going. And with regard to weight loss, some people feel that if they can't exercise, they can't do anything. but we try and tell them even walking around the block and seeing a tree and going to that next tree, whatever you do to keep active. But, it's calories, it's exercise, but it's so much more than that. It's so much more than that.
You talk about activity, and I want to ask this next question to Chad. And when you think about activity, is there a definition out there on what people are, starting from a fitness and performance standpoint?
Mm-hmm.
What are some of the advice that we're given to patients and clients as far as the body moving?
Right. Well, there's a bit of a dialogue going on right now, actually, between activity and exercise. So activity is described best as low discriminant aerobic movement. It can be anything over a given period of time at very low heart rates. Okay, and it does have some benefits, typically around reducing blood glucose. But when you look at exercise, now you're looking at increasing levels of intensity designed to increase one of the 4 variables of exercise, be it flexibility, muscular strength or endurance, cardiovascular capacity, and motor skill control. Okay, so activity doesn't necessarily create an outcome. And so that gives the public right there a bit of a confusion, because they say, hey, I'm moving more, but nothing's happening. Well, it's not put into a system that creates an outcome. So, but it's not beneficial. But when you're asking somebody for advice or you're paying money for a program, now you have to move beyond activity into some kind of a design that generates an outcome. And that design is predicated on an assessment and health status.
I agree. You got to have a plan.
Yeah, and this is it's interesting. This is a theme that we talked about for those of us that are new to the show. Something we talk about. You have to be intentional. You have to plan. There is a way to design your day to day. We've talked about even little things even though I'm not minimizing anything, but things like just waking up 15 minutes early may just set the proper tone for the day. I know Dr. Jabbar and I have talked a little bit in the past, and you probably know some of the more studies than I do, but even some of the benefits, even as 7 minutes a day of just some movement may be beneficial in helping to attack this issue.
Yeah, Dr. Ju, you're absolutely correct. In the weight loss clinic, I try to get people moving. When I see people in the weight loss clinic, everybody is in a different spot. So my first initial plan is to get them moving. As a matter of fact, we know that 30 minutes of brisk walking 5 times a week reduces all-cause mortality 30-35%. I don't have a pill that does that. So and people oftentimes tell me, well, is I'm going to lose weight with exercise, and I tell them that the data is clear. 90% of weight loss is nutrition. Exercise becomes very important for maintenance. Now, to keep the weight off, you need to exercise. But the reason I want people to move earlier on, because of one word: inflammation. When you exercise, you produce the most potent anti-inflammatory material available. And that will help heal the body, from multiple standpoints. All these medications that we give them hits particular receptors, whether it's an insulin receptor, whether it's a leptin receptor, whether it's dopamine receptors. If these receptors are inflamed, they're not going to work. So exercising, even though starting a little bit, 30 minutes of brisk walking 5 times a week, can do a lot in making sure that inflammation goes down in the body. So some of the medicine that we do give them actually work better.
Barbara, when it's interesting. When your perspective on this is, you've had a lot of involvement in the community. What is your approach when you kind of come into families that may or may not have some of the resources to get better, to make those sometimes those design change, or they might be feeling overwhelmed and say, oh my gosh, I can't do this, and you guys are going out there and them in the community? How do you kind of overcome some of those barriers?
Absolutely. We've done a fair amount of work in childcare in schools. So we just reassure families that, if the schools are doing our part and we're doing our part in childcare, we're getting a fair number of those minutes of activity in a day. And then just having conversations with family about how many minutes are left. We say preschool children need 120 minutes of activity a day, some of it moderate, some of it vigorous. And then we're communicating with parents how much might be left at the end of the day. It might be 30 minutes. The nice thing about activity is it doesn't need to cost you anything. We have here in DuPage a wide variety of options, from our forest preserves to our parks to our YMCAs to our low-cost rec programs, scholarships available for families who can't afford it. But there are so many things you can just do at home. If it's walking the dog or setting those healthy habits very early on so children grow up enjoying activity and carry that with them through adulthood.
Talk about on the show a lot is having that equitable access. And certainly some of the challenges that are out there is when you have some communities that may or may not have some of those resources, grocery stores, do they have these other kind of resources? And it's interesting. When I think about some of the barriers that are out there, number one, I think of access to affordable, healthy foods. And so when you're looking at communities that are at risk, they just don't have those kind of resources that they do out here. Second, there's been a high amount of exposure to marketing of less nutritious foods in some of those at-risk populations. And certainly it's certainly cheaper to have to go ahead and get a bag of flaming hot Cheetos versus get a side salad in some of the communities, and that's certainly a big issue when we're looking at some of the disparities. And lastly, there's certainly limited access to safe places to be physically active. So I'm glad that there are some resources that are out here that you guys are seeing. What about from your perspective, Dr. Davis? You're seeing patients that come in and they may tell you, hey, I don't have these kind of resources available. How do you kind of help them overcome some of those barriers?
I think overcoming inertia, overcoming that, and getting new habits set. And so I think if, like you said before, if you done nothing, and then you can go from there. I tell people, you lose weight in the kitchen, you get fit in the gym. So the calories are always there, but the exercise for maintenance, as Dr. Jabbar was saying, and to make you feel better. It's free dopamine and serotonin. The exercise will make you feel better. And once you feel better, you want to do more. And it kind of goes from there. So I think just kind of getting a plan and getting over the fear of starting. It's not the end of the race. It's that first step. You got to get them to just get out there and go.
How do you, Dr. Jabbar, how do you incorporate behavior and speaking about some of these kind of reservations that people may have, how do you incorporate that in your practice? Because I know for me, from my end, I'm blessed to have a behavioral health expert in my practice that I can actually just reach down the door and say, hey, can you help me out with certain things? But how do you go about incorporating behavioral changes into your patients?
Well, Dr. G, I think a lot of patients can do some simple things. I try to get people to do some meditations. There's a very nice app called Calm. I have a lot of my patients download that app. It doesn't cost you anything. You pick a background noise you like. I do it since I have 4 boys, always stressed out. I pick the rain, falling rain. I like that noise. And then you click on breathing meditations. So you take a deep breath, you hold it, you breathe out. You do 15 minutes of that at nighttime. So that has been shown to help bring down cortisol, which is our stress hormone. And we know that cortisol is a steroid, right? So that's your fat making hormone that will make you make fat, and not only that, is very pro-inflammatory. So anything we can do to bring that down. So it could be as simple as meditation, 15 minutes at nighttime. You can also in certain practices, if you have a therapist, a psychologist, you can utilize them to do cognitive behavioral therapy. And now we know the evidence is very clear. A study came out of the Mayo Clinic not too long ago that cognitive behavioral therapy and meditation is equal to an antidepressant, is equal to an anti-anxiety medication. So these tools of meditations and ways to relax are quite effective, and you can I incorporate some of these simple things such as meditation easily in my practice.
Yeah, I think one of the things is this is one of the reasons why I wanted you to come on the show, because you really kind of keep your head in the books on some of the literature out there, and I've been interested when I found some of the literature myself, researching things for this topic, and you're finding that there was a study there where they followed individuals for about 8 years, and I believe it was in England, and they looked at the individuals that had behavior modification along with the lifestyle approaches to their weight loss to deal with obesity. And certainly when they got to 8 years, 50% of patients maintained 5% more weight loss 26.9% of patients achieved more than a 10% weight loss and maintained that at year 8. And then 11% of those individuals maintained more than a 15% weight loss. So you can speak to the volumes of the impact of having a multidisciplinary approach and weight loss success. Chad, when you're working with clients and patients, how do you help design things? Let's get into the design aspect, because again, I could be a person I'm married, I've got kids, and I got, I wake up in the morning, I'm on somebody else's time and somebody else's dollar.
Right.
How do you help to design that in your clients that you're working with the obesity epidemic?
Yeah, well, for me, there's two basic sides of the equation, I call it. So, if you're functioning in a relationship with low support and you're kind of doing it by yourself, then you have to look at behaviors that incorporate a high level of routine and very low cognition, because rote and very, very static in how you decide what you're going to do. It's very preset and very unemotional, because to have to decide something every day is very fatiguing. And you look at all your major life decisions, you weigh it one time and then you go with it. You don't decide every day to get married again each week. You don't decide to go to a different college once you get on campus. You don't decide to move once you buy a house. So when you decide to get healthy, you don't say, man, I'm not going to have this cookie, but tomorrow I'm going to have it. To weigh that every single day is fatiguing versus saying, I only have it at this time, and then that's it. If not that time, then I don't have it. It's not an option for me to weigh. And so for low support environments, we tend to move into more of that design. And then for a network that's more supportive, we tend to include more of those individuals. So we would bring in their spouse, bring in their children, bring in their support group, and counsel their entire group, because that entire group is going to be able to work with that individual over time.
But the whole family will benefit that way, not
Correct.
just the person.
Correct.
You'll help the whole family.
Right. You don't want to have somebody, reward you through sabotage. Oh, you're doing so good. Let's have a drink now. Or let's celebrate with this. And so it's helping them to understand how to reprogram their achievement, their success, to celebrate in a way that keeps people on track and is still restorative.
So, it's interesting when you talk about you're really getting to the heart of relationships, and every time we see success stories, you certainly see some stories where they're not having much success, where the relationship are there to support. Say, hey, hey, Dr. G, I'm losing weight, I'm looking good, I'm feeling better, but I don't have the support of my spouse in this process, or my spouse thinks like something's going on, and it's interesting because you want to be surrounded by people that are going to support you to reach your goals, and not people that may take away. And sometimes we see a little conflict. I'm sure you guys have seen in your practice, Dr. Jabbar, where you might see somebody be successful and the other person might be sitting there in the chair in the same room and say, they're not kind of really supporting that love. And then that can create more stress. And then next thing you know, you fell with that person 6 months later, and sometimes their weight's back up.
Absolutely. And as a matter of fact, in the weight loss clinic, when, a patient comes in, a lady, usually her husband is with her, I try to engage him a little bit and I say, hey, how about you guys do this together? Because I found that when couples do this together, whatever that you do together, whether you pray together, whether you exercise together, whether you lose weight together, I find a lot of success when they do that. So I usually engage the spouse and try to encourage them. And 9 out of 10, next week I see them in my office. Mm-hmm.
So going back to the relationships aspects, it's interesting because you remind me, as you're telling your story, you remind me of what I told my wife, a few months ago, and said we want to do more things together, but you have to kind of build that into your schedule, and you have to let's move together, let's do things together, let's get the kids involved. Mm-hmm. That really sets the tone. Barb, I want to ask you this, when it comes to like the money, because there's a big financial cost when it comes to obesity management. Can you speak on behalf of what are some of the financial implications that we're seeing when we're not really properly addressing this issue? I can only imagine the amount of healthcare spending on this issue is just escalating and escalating and escalating.
Absolutely. And certainly that's what the research shows. Through the years, we're spending more and more and more on healthcare related to chronic illnesses, which is, of course, a direct result of obesity. So, and people are seeing it in their health insurance premiums. It just affects people in all ways. I wanted to make a quick comment about, you mentioned when families can't afford to buy healthy food. Forward is a coalition of 1,400 partners throughout DuPage County, and the food pantries are a big part of this. And our child care centers have worked with food pantries too, just to make that kind of food available. It used to be where people were just happy to get any food, and it was boxed food and packaged food. They've made such progress through the years, improving the quality of the food that's available through these food pantries and community gardens, and the list goes on and on. I think people are very, very focused on, it's tough, it's expensive to eat healthy, and what can we do here in DuPage to make it easier for families?
It's interesting as I'm reading more about the things that we can do. I mean, this is a public health issue, public health number one, public enemy number one, and I like to hear that there's some good things that are happening out there. There are people that are trying to fight for those government dollars to do grants. Maybe you get, in at-risk neighborhoods, you get those individuals through grant money to open up the built environments and develop that for people to have an area and an ability to thrive.
It's a ripple effect. Once you start from there, everything else gets better. What seems like a small change all of a sudden comes into a bigger change. The whole family's affected. The children are affected. They're more engaged. They want to do things together.
Sure.
And it goes from there.
The other thing is even the child care and adult food programs or the food school lunch program, I think we've made great strides through the years to make them much, much healthier. And in child care centers, just simply, we're not serving juice anymore, has made, a great deal of change.
Tremendous.
And what we can say to parents is, we've got you. We're serving healthy food for breakfast, for lunch, and snacks in child care centers, and throughout the school day, healthy lunches. So we'll do our part with government money necessary, just to make sure your children have the right start that they need.
Well, it's a terrible feeling to feel helpless, that you can't control yourself, your family, your environment. It's an awful feeling, even if you know the quote unquote right thing to do, but then you can't implement it. So any resources that you can give people to get them on their way is huge.
Oh, absolutely. So, Ann, I want to ask you a question. As you're thinking about, just kind of pick a random, I'm going to pick pick the brains of the panel. Have you seen any use of more technology? Everybody got a watch or something like that. Have you seen that in your cardiology practice? Are you using that at all to help advise patients?
A lot of people are coming in with the Fitbits that they can check their heart rate and blood pressure. And I'm just glad that they're exercising to check their heart rate and blood pressure. You know what I mean? So I'm all right with that. But the technology is amazing. You can have an app that you can just put your fingers on the phone and it'll tell if you're in atrial fibrillation, which is an irregular heart rhythm that sometimes people can get. So it's amazing the things that you can do. You can check your food, you can check your calories. I think all of this is secondary to the fact that you're planning and you're trying to do something different. So however that manifests itself, whatever makes you do better choices, I'm okay with.
Go ahead.
I totally echo what Dr. Davis said. In addition to that, I see my patient use MyFitnessPal, and it was kind of interesting. Today, I had one of my colleagues take in, and she told me, she said she's interested in weight loss and trying to help her with some stuff. And she said, all I did is just told the patient to track their intake in this MyFitnessPal, and she lost like 10 pounds in about a month or so. So that goes to say that if you just at least monitor things, we used to say, don't weigh yourself every day, weigh yourself once a month or whatnot. Now we say, go ahead, weigh yourself every day, so just kind of like you need to know how much money you got in the bank, because by knowing, how much to spend or how to, so just that, weigh yourself every day, so your fluctuation, and therefore you can actually make some healthy choices.
Excellent. I want to change topics a little bit. I want to talk a little bit more about some of the disparities that are out there. Well, and Barbara, thank you for giving a little more a little more story on what you guys are actually doing. Why don't you tell me a little bit more about from the childhood perspective? When I was doing some research and prep for this program, I came across something that I thought was it really vibed with me well about your background and being involved in the nutrition and physical activity, the self-assessment and childcare. Can you speak a little bit about that, on what you guys are doing? Because I think this gives a big message to those that are listening right out there. They have children, if they have children, but being the community at large. So how are you measuring outcomes with programs like this? Because obviously you're trying to do something and measure something.
Yeah. Thank you. Our tool is the Nutrition and Physical Activity Self-Assessment in Child Care. It's a self-assessment tool created by the University of North Carolina. It's been around for over a decade, and it's evidence-based, which simply says that the programs that are intentional in putting forth changes actually sustain those changes over time. And we do a variety of things. People have improved menus. They've improved the number of minutes of physical activity each day. They've added more nutrition to curriculum for young children. They've added more professional development for their staff. So we started out saying, in our professions, we may not have had a lot of coursework in this, but now there's training available. To help the staff. Family or child care centers are doing a whole lot more in communicating with families and passing this information on. We've also, from the health department, we were able to give implementation grants, so changes. They had some funding to actually make it happen, because you can imagine that's tough. And we targeted centers that serve primarily low-income families. So they're not always the centers who are the most lucrative. And we provided a lot of technical support and other things. So what we measured was that people did what they said they would do. They looked at action plans, they set goals, they met those goals, and then we followed the anecdotal comments. What did the staff say? They were more intentional. They learned a lot themselves. They were making changes personally. Their curriculum looked different. The activities that they do with children were more focused. It wasn't as much child choice, and a variety of other things. And in one center, very early on, the first year we did some pre and post, and we actually found in our Head Start programs that those centers that went through the knapsack program saw just slight changes in BMI. It was more favorable compared to the centers who didn't have that same kind of intervention. So it's hard to measure BMI in preschool programs. The schools are doing a great job of that because we're partnering with the regional office for education. That data comes back to the health department. We promote it, and we know what the data is. So those are some of the outcomes.
Well, thank you for sharing some of the outcomes. And it's interesting when we think about in our practice, we see them back for a follow-up. And so we're trying to measure outcomes a lot in health. Chad, when you're looking at your perspective, we know that obesity management it's going to take time. People aren't going to lose 30 pounds tomorrow. Even though we live in a society of quick returns and instant gratification, we've got to take our time with this. So how do you help coach people into saying, listen, this is going to take some time? How do you get somebody from A to B, and knowing that it might not be a straight line, it might be a little curly line, and eventually get there?
And what I found is basically through their assessment, we kind of have a red, kind of yellow, green, and I try to get people initially out of kind of this red zone of high risk factors and putting them at risk for a chronic disease. And then once we can get out of that zone, then we can take our time with getting to the other metrics of aesthetics. And so for individuals, I kind of go aggressive at first if they are in the red zone. And then after they get out of that and they work on more kind of aesthetic goals, we can take it a little slower or moderate the changes. But that's how I look at it, because when people come to see me, I mean, it's usually dire, or it's something that they want to achieve in a given period of time. I don't have people that are just coming because they need to lose a couple pounds. There's some kind of impending medical condition, or it's a significant event that they need to get to a certain point, okay? But nevertheless, I still tier the recommendations, and I say, hey, this is a transition phase, not to be confused with maintenance, not to be confused with long-term management. And so I typically have 3 levels of counseling and 3 levels of progress that we accept per week that we measure.
When I think about the patients that come into my practice and newer patients, the first things first, as a primary care doctor, I want to get some numbers, and I think the physicians on this panel say, you got to see some data. Right. You got to see some objective data. Right. And certainly that's how we are in medicine. We judge people based off of data. Mm-hmm. You're either healthy or you're not. And it's like you either got diabetes or you don't have diabetes. So we have this black and white kind of approach on how we see things. And the first thing that we do is we say, all right, let's get a baseline. And that's one of the things that I say is before people have to go visit Dr. Davis and she's thinking about a stent in their artery, we have to get people to get in the door in the first place. And when we think some of the challenges out there, there's still, number one, a lot of people that don't go to the doctor. For whatever reason, but we're trying to get people to go into the doctor. Number two, if they go into the doctor, they may be seen, but then they may not go for their labs. Right. And I know I'm not, I can't see through somebody's skin and see what their A1C is going to be or their cholesterol is going to be. So number three, that follow-up, and it's interesting, as Barbara was talking about her program, is there's a follow-up, there's measuring. Let me ask this to Dr. Davis. Patients are coming in, and of course, you're from a cardiology perspective. Really, I see a lot of what you guys are doing is really going back to making sure. I mean, the numbers, you got to have some good numbers, because otherwise the numbers are bad, and somebody presents in a very tenuous person presents in a very dire situation, and then you're all of a sudden, you're doing a huge workup. But how do we kind of avoid getting to that point that they say, oh my gosh, this is the big one, and I'm gonna have a heart attack or things like that. How do you avoid that from your perspective?
Well, the good thing is that they're at least coming to us in the first place, because like you said, some people don't. But usually I try and ask them about their families. Do you have a family history of heart disease? Mom, dad, brothers, and sisters. Some people come in and they say, everyone in my family had a terrible heart attack at the age of 50. And I'm like, let me guess, you're 49, right? And that's not uncommon. So you got to have some amount of motivation, but like you said, the numbers, how much do you weigh? What is your cholesterol? What is your sugar? What is your triglycerides? Other factors? Do you have any other medical issues or things like that? How has this affected your life? And what can we do to change that? And thankfully, with diet, exercise, lifestyle, as well as some medications that we have now that were not available before, we can hopefully help them get to goal. But letting them know that it's not just a number, it's the fact that we're preventing disease and stroke and diabetes and having you be an active and engaged older person. Some people say, oh, I don't want to be old. I'm like, you're crazy. You want to be old, but you want to be happy and healthy and engaged and out there and not just in a chair.
Go ahead, Chad.
Can I add something to that? Yes. Because I do see people, when they come in, they typically have these narratives. And we have these numbers that we try to manage, but the numbers don't really tell the narrative. And like what Ann was just saying, there's these innate belief systems that if I don't go to the doctor, I'm not sick. I could be sick, but if I don't go there, then I'm not sick. And it's kind of like, how do you aggressively penetrate these narratives? Because in our society, if you're working and producing, then that's fine. We don't seem to really value a continuum of expression as long as we are expressing whatever level that we feel that we should. And then it's only in our mindset do we get to a point and say, wow, you know what? I'm really not what I'm used to being, or I'm coming up on this, impending doom here. My dad died at 60. My mom died at 50. I'm like Ann saying, I'm 48, or I'm now single. I actually got divorced because of what was going on with me. I need to change this now. And so the current system really doesn't do a great job of addressing these societal narratives. We're still stuck in managing somebody's conclusion. And that's typically what we end up seeing versus trying to get ahead of the story and change their mental frame of, hey, you don't have to go down this path, but right now the system is not designed in that way.
It's interesting when you say people don't have to go down that path, and that is the mindset. I kind of tell a little personal story that I remember, going to a relative's house as a kid growing up on the East Coast, and I saw my particular relative take out her dentures. and put them in the little wash and everything. And I'm 6 years old at the time, and I'm looking at my brother and I'm saying, man, I can't wait till I get dentures. I can't wait because I figured that was a sign of getting old. And it's like, oh, yeah, I'll take my teeth out. That's the thing. And then you realize, you go, wait a minute, I can do something about that. I can brush my teeth. I can go to the dentist. Same thing happens when you think about chronic disease. People say, well, my mom had diabetes, my dad had diabetes, my mom was obese, my dad was obese. They had heart attacks, and they just resign themselves to getting that.
Nothing is inevitable. No. Nothing is inevitable. You could turn right instead of turn left. But at least there are things that are tangible that people can do on their own to have some control of their life and impact their health.
Dr. Berg, what is your you might see some patients that are diabetic, they've got heart disease risk factors, and they'll say, I know I need to lose weight, and I know if I lose weight, these other metabolic conditions will get better. But how do you deal with that in that right thing? Because you're not going to let somebody sit there and if they're a walking time bomb explode. You're going to try to do something now.
Yeah. So absolutely. So like you said, we run some baseline numbers. So we dig in deep. We dig into if you have insulin resistance. We dig in if you have leptin resistance. We dig in if you have vitamin deficiencies, B12, vitamin D, and try to fix some of these things. But the notion, we have heard of this thing that prevention is the best medicine, right? But our system, like Chad was saying, is not designed for sort of prevention and quote unquote wellness. We seem to be waiting for patients to have their heart attack. We're waiting for somebody to have their end stage whatever, and then we just have to deal with it. But I think there are some interesting changes. We're saying now some insurances are covering wellness visits. So I would, and the patient doesn't have to pay a copayment. So I would encourage all my patients. You don't have to be quote unquote sick to see the doctor. You can go and get some baseline numbers to see where you're at. And to me, that's where things needs to start. But you're absolutely correct. If they are coming in with some of these, end stage things, we have to deal with them aggressively. But we tell, interesting thing I'll mention that, in our weight loss clinic, it's very interesting to me. I saw a patient last week, their BMI, which is kilogram per meter squared, which is weight divided by height. BMI above 40 was 45, which is class 3 obesity. This patient was 70, have chronic kidney disease, congestive heart failure, over 300 pounds, and now they're being referred to me for weight loss.
They should have been referred a long time ago.
I was thinking, so we have to go even educate some of the physicians to say, refer earlier, where, we can, because if you give me the patient a little bit earlier, there are more stuff I can do with them. I can get the good exercise person to get them moving and whatnot. So the idea is attacking these things as early as possible.
I think we're one of the things I take away. Yes, we need to do better, certainly from a practitioner standpoint, and take advantage of our relationships with other individuals that are similar stakeholders in dealing with this epidemic. Our nutritionists and our fitness folks, our county resources, because there are resources out there that are there for people to hopefully give them the chance for success. So we got about 5 minutes left, and what I want to do is just kind of I mentioned at the beginning of the program we talked about this is the chief complaint. How do we attack this obesity epidemic? And now what we do in medicine when we're about to be finished with our patients at that particular visit, we call it the assessment and plan. So for our assessment and plan section, I just want to kind of ask each panelist to kind of give me a few take-home points. So I'll start with Chad and say, Chad, what are a few take-home points that are out there for our listeners and our viewers on how to best deal with the obesity epidemic?
I would say that one of the biggest confusing points that I want people to understand is that in health, a lot of the behaviors that you're performing today can be distant from the outcome that's occurring. If you start smoking at 12, cancer doesn't show up for 30 years. You may have a donut today, but you don't see diabetes for 30 or 40 years. And conversely, you may go on that walk this afternoon and not see a large change in your health. And so behavior is only looked at over time. You can't make a choice and think that choice today is going to be valuable. It's the commitment to the option, not the option itself. And so in health, I would say routine is paramount and dedication is very critical.
Thank you. Barb, I wanted to ask you the same question. What are kind of your take-home points today? We've had some really good discussion on this issue, and I guess it's a broad topic, and we'll probably need to have some more discussion on this, but what are kind of some take-home points?
First, I just want to talk about you're not alone. I love the fact that we talked about prevention, and clearly that is forward and the health department's purpose. That's why we exist. So there are 1,400 partners throughout DuPage County who are doing something in, weight loss or obesity prevention, and we're here to help you. We've got an annual meeting. We've got a website, Forward DuPage. So I just encourage people to check into that. We're at the fair this year trying to think through healthy eating and a fair-like environment. The other thing I want to mention is simple messages. Both Forward and the Health Department adopted for children the 5-4-3-2-1-GO message. At 5 fruits and vegetables a day, 4 servings of water, 3 servings of low-fat dairy, 2 or fewer hours of screen time, and 1 hour of physical activity, 1 or more. And I think from a family perspective or a child perspective, if you could just wrap your arms around that and just make those 5 healthy habits a part of your daily routine, you're really on the road to good health.
Wonderful. Dr. Jabbar, some take-home points on obesity.
I think, Dr. G, once again, thank you for having me here. I would say all your listeners should just take some bottom line point from me. From nutrition standpoint, I would eat less carbohydrate, less processed food. Start eating out of the refrigerators, not out of the shelves. The stuff on the shelf is so bad, even bacteria doesn't want to eat it. Start eating less processed food. Number 2, 30 minutes of brisk walking 5 times a week. Number 3, meditation. Meditate, do not medicate. That's what I tell my patients. And I'll just close with this. I want every listener tonight to know where they're at today. Go figure out where your BMI is today. If your BMI above 25, you're overweight. If your BMI above 30, you are obese. If your BMI above 40, you are morbidly obese. And think about this interesting statistics. If your BMI above 40, your chances of reaching 70 years of age is 50%. It's a coin flip. So put that in perspective. If your BMI between 35 to 40, it's a little bit better. You have 60% of reaching the age of 70. If your BMI in the normal range from 22 to 25, you have very good odds, 80% chance of reaching 70. So realize that obesity kills, and on average, obesity and morbid obesity reduces life expectancy on average by 10 years.
Excellent. And Dr. Davis, just the last few words.
Just get out there and try. All you got to do is take that first step, and then the rest, you got to get a plan and go from there. Thanks. And I echo all the other sentiments from your panel here. They're all wonderful.
Excellent. And my few words I'll say before we close it out. Number 1, I want people to take more investment in public and private investments in the community health. Number 2, we should have more support at all levels of government to deal with obesity. Number 3, we should utilize culturally sensitive communications and language. Number 4, just involve more community leaders. Involve everybody that's out there. Take advantage of the resources, and we need to fund this better. All right, guys, that's about a wrap. So this is, again, Dr. G. I want you guys to stay tuned next week. We're going to be doing Obesity Wars Part 2. You can follow me on Facebook, follow me on Twitter, follow me on Instagram at To Your Health, Dr. G. Check me out on my website, www.drmarkgomez.com. Take care, guys. Peace out.